Good evening, dear friends. It's such a wonderful thing after a very long time getting involved in something complete on a virtual platform after COVID. We used to do a lot of these kind of educational meetings many years back. But um, over the time, I've seen that there are a lot of fantastic contents in the social media and in the realm of education. And but one thing which is missing is something which makes you start thinking, something which is not just giving some sermon or the standard rhetoric of from the published work. We thought, why not create something from the thinking platform and which connects many aspects of our practice, from a clinician to the thinking clinician to the scientist in you, and also try to bring some inspiration. So, after trying various concepts, we thought we'll freeze on to this one. We experimented with many other in the past with some kind of uh, acknowledgement of success, and sometimes we felt that it was uh, very similar to what has been already being done. So the thinking eye is a uh, concept of having a discussion platform a few times a month where we go looking at podcasts where we create some very unique concepts, a YouTube channel which talks about highlighting very uniqueness of of surgeries like the ones which you are doing today, or a technique or a case presentation. The translation classrooms is something which excites me the most, is where we try to have a live discussion from our scientists, from physicists, from people from different branches of medicine and research, where we go to the area of their work. Like, for example, somebody is working on a hardcore proteomic works, go to the area of work, see how does it change and how does it help us in our practice. And so we created this content looking at the future and something which can transcend many layers of interests and thoughts and many other things which we have, and sometimes it gets too complicated with the current scenario. So we will have a community where we will share what is going to come next, and we try to create a completely new way of bringing out uh, education through these platforms. Something like, say, something in new imaging technologies in retina, or the AI and its role in, say, identifying different type of macular edemas, and these kind of very unique ones, and not just from one specialty. It's from end to end, from the tear film to the to your brain. So that's what the whole concept of thinking eye is. And like in this cartoon, it's everything is about bringing from ground to zero. And I call this the romancing the cells and optics. You need to have a very strong romancing feel with those cells you work with, the optics you work with, the imaging you work with. We try to create not just something which is published and discuss around it, because for me that doesn't excite me. What excites me is when you don't think there is a box and you start looking at everything outside the box, inside the box, and believing that there's no box in your thought process. We have real stories, real scientists, what impacts your future. Bring in everything, neuroscience, neurobiology, and try to bring what is hot from press. And many colleagues in my team and a lot of my friends who keep traveling to different meetings, will ask them what did they learn new. So this is what we want to bring this in the thinking eye. And we need your support in not just being an attendee, but being participant in whatever format you want to. Have a great case, you can write to us and we can share the case and we can discuss. If a complex patient where you want people to discuss, then you can write to us and we can create that platform. So today, what I'm going to discuss today is a very interesting concept called ray tracing revolution. And I gave this Da Vinci Medal lecture at the World Keratoconus Congress, World Keratoconus Congress, on a virtual platform. So I thought, why not share this discussion with you all, because this is something new, and it took been a year and a half for me, and close to 1,000 plus patients on whom I operated, where I've learned a small part of it. And I think to have any financial disclosure in this technologies, and I'm not part of anything other than a simple user. So whatever I'm going to discuss, irrespective of the state of my 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 serotonin and oxytocin rush when I'm explaining about this, is all driven by my passion on this technologies, nothing financially driven. So the question when we look at any keratoconus is about, can ray tracing be used to remodel the corneal shape? Now, what is ray tracing? Ray tracing looks at every layer of your eye and how it creates, and what every light, every beam of light, and how it forms on your retina, and from there you map it, and you're like backtracing that every beam of lights, and then you see how it has an impact on the cornea, and where does it exactly form on your retina, the angle at which it forms. Multiple factors are related to it. Pupil is one of the related. The shape of cornea is one of the related status. This is how it is. For example, if you're looking at the lace of lights, and you see that some part of your retina, cornea, so is not proper, some rays of light would form in different parts of your retinal plane. And then if you backtrack them on each of these layers and see how you can correct it, and that becomes a ray tracing laser for the correction. So IVIS, what I use some of their slides, is a company which pioneered the use of ray tracing in a very, very big way. Now we have Alcon also with the Wavelight Plus, but Precisio was the abrometer, because for any ray tracing, you need to have a good diagnostics which picks up these images. So you have a Precisio, which is a abrometer based on Hartmann-Shack system, which looks at acquisition of these images. Quite an innovative tool. In fact, it is where you don't even need uh, a technician. I mean, in our case, we are using a technician, but they promote that you can keep your chin, you have a certain steps, you follow the steps, it acquires itself. It has an ultra thin 30 microns blue light, something similar to what we have in Pentacam. And because this blue light has minimal effect on your tear film and very good repeatability. The scattering of this light, the principle of this blue light, helps to measure the epithelial thickness independently from the lacrimal fluid. That means it dissociates the lacrimal fluids and measures the thickness. So what does it do? It gives you different maps. It gives you a map of your epithelium. It gives you a map of your anterior cornea. It gives you a stromal map of your stromal surface, the posterior cornea, and the total. The amazing part of it is that it is giving you the maps of every layer of your cornea, starting with your epithelium. And it tells you how the epithelium is like a lens, and then it moves to the anterior stroma, the stromal surface, and the posterior corneas. And then after that, everything is on a cloud base. It doesn't have a software portal. It's all cloud based. So you can sit and you can plan it remotely with your iPad. If you log in, and your planning is there. And once you log in, then the planning comes on to the laser machine, and then anybody can fire these lasers. What's the second most important thing is the entire ray tracing principle of this is based on measuring the ideal pupil size. And that is the most important thing. When you look at an ideal pupil size, there's something called as a P matrix. P matrix is the pupil size measurement tool. It measures the pupil in six lighting conditions, which a normal person uses, and it gives you what is an ideal pupil size like this. This is photopic, this is cotopic, and usually, most of your topographers will give you this. But see the difference. There's a huge difference between your photopic and your ideal pupil size. And then once you get an ideal pupil size, then what it does is it gives an laser planning on that pupil size, not on a standard 6 or 7 millimeter pupil. So this is something which we all have to understand. We are all used to saying, okay, the photopic pupil is 4, and I will give the laser, my zone is 6 millimeters. This is an arbitrary number. But instead of that, it gives you the pupil size. Your optical zone is based on this, so that this is where you will have the laser being fired as we see in this picture. That's very important thing. So laser starts with every layer. For example, it starts with the epithelium. In this, here the epithelium is myopic, and here you can see that it measures the epithelium like like a lens. And if the lens, this is a myopic and this is an hyperopic status. And this is exactly what I told about the pupil. And you can see that the whole ablation pattern falls exactly on the pupil size. And we did this work, which is interesting. The P matrix, the ideal size of a pentacam, and what is the ideal pupil size, there is close to around 2.5 millimeter difference from your ideal pupil size to what the pentacam gives. So your functional optical zone is different in different people because you're measuring from one particular tool, and this also has a huge role, especially when you're working on um, um, cataract surgeries. And this is what happens. This is how the laser is. It is not an oval shaped ablation pattern. It has a different shape based on how the ray tracing looks at your eyes. And then you, based on how all the ray tracing, it has this is your eye, and this is how it is. And then it has different levels of thickness. You can see ablation thing. That means it's not the same all throughout the eye. It's based on how you shape the eye. Some place it has to, just like somebody, uh, the person who owns this company is from Italy, very close to a place where the Michelangelo made his famous marble. But he always compares that. You look at the David in Florence, the shape of David. It's just that some places, if your muzzle or his hand, you're chiseled off more, and some places you left the marble as it is and rubbed the surface. So that's what forms the perfect sculpture of David. Exactly the same thing. You don't need to knock off everything. See, normally, traditionally, our lasers are everything gets knocked off. If it's 40 microns, it's 40 microns everywhere. But here, it's 12 microns in one place. There is different things, different 20 microns. Some places there are only 4 microns because it's chiseling the shape of cornea. Like you're taking out what is not necessary, and then you get your marble, then you get your David, then you get what the shape is. And this is one more example of how the shape is according to how your cornea has to be reshaped. And how does this shape form is because once all the rays go to retina, you backtrack it and says that if I change the shape here, if I ablate a little bit more here, if I ablate a little bit more here, then all these rays of light will form perfectly at the point here. And what the point which can be perfectly placed there is the one where you need to shape the eye. And that's what happens. And these are all the platforms to do it. And this is how it is. This is from the cloud. And then it also gives you an expected post-op measurements. Interesting here is it has an inbuilt cross-linking machine. It's not outside, it's inside the machine. After you're done with your lasers, you click of a button, the laser platform changes from that excimer laser to a UV laser source. And UV laser source does the cross-linking. And how does it do a cross-linking? Because it has already mapped the stromal pachymetry map. It knows exactly which area is thinner and which area is thin. And this is stroma. It's not with epithelium. That means it already knows after you've shaved your cornea, how much is your residual stromal thickness. And then it gives you the whole platform gives you different total fluence in joules out here, which is based on the Mesotas M protocol. Amazing, technologies which thinks so much, takes the lasers, corrects your power, knows the stromal thickness in each zone, and based on the stromal thickness, it maps what laser has to be given after you're done with your riboflavin installation. And there's a few examples of it. You can see you can nearly make sure that it becomes close to normal looking corneas. Epithelium is probably very important because we all know that epithelium forms a very important part of your cylindrical corrections. And like in this case, it's a central myopic zone, and your rays of light from epithelium itself becomes irregular. So every layer of corneas have different, every type of corneas have different types of epithelium. So what is an ideal epithelium thing is tries to reduce this irregularity as much as possible. And you can see that this is what an expected was. The machine predicts if I use this much of laser, like I said, the laser platform starts with epithelial mapping and how the ray tracing can change the epithelial mapping itself. And that's why you get such perfect looking epitheliums. So why are these epithelium important is if your epithelium is like this, is inducing at least 1.5 diopters of cylinders and also myopic shift on the epithelium level itself. And you can see that that has completely become around 0 or zero point 0.2 diopters. So that is why the regularization of epithelium is very important. So let's look at this picture here. In a healthy eye, if you really see, there's not much of a change in asphericity or axis when with or without epithelium. That means it can artificially simulate the keratometry with or without epithelium. This is like a simulated keratometry. But in an irregular epithelial profile like this, you can see that there's a huge change. The person has small asphericity that completely changes, and your axis completely. This is important because many times post cataract surgery or post any other refractive surgery, if you put a toric lenses, you have challenges. Epithelium can change the axis. So with and without epithelium here, the axis has changed by more than around 20 degrees. And you can see that the total astigmatism, which was 1.6, becomes 0.49. That means you virtually reduce 1 diopters of astigmatism just by without epithelium. This without epithelium is more of a virtual one because it knows what the stromal changes are. So what is important here is that epithelium has a huge impact in the quality of cylinders. And if you don't regularize it, like in this case, you end up in having irregularity starting with the epithelium itself. So let me run through a few around close to we are now around 14 or 15 months now. I've already operated around 100,000 patients where we did laser-based procedure for keratoconus. We did all kinds of cases, and you can see that all ablation patterns, which is out here. The one in the green is the transition zones which helps to regularize the cornea. And this is how it works. You can see that this area out here is ablation, and you can see how beautifully the ablation pattern follows the change out here. And interestingly, the ideal pupil size, the whatever we get around 6 or 5.1, the machine here, once the patient is here, it tries to fit to that pupil with adjusting the light itself. So the machine adjusts a lot of light beams so that you reach the pupil size here is exactly matched to the pupil size what you get in the diagnostic room. So it's exactly the same pupil size. One of my most happy situations has been Pellucid, and we operated close to around 20 plus patients. You can see that beautifully regularization of refractive error. And you can see that this patient virtually were able to open up that the sign. And here we can with nearly, because what happens is it opens up this zone out here, and opening up that zone opens up that beautiful space of regularization for you to see. This is a post LASIK ectasias, and you can see we achieved something similar to what we would see in just after the surgery. These are the few cases we can see again a pellucid here, and you can see that this is opened up here, and this looks something very similar. Um, we reduced the cohire order by 42%, which is very, very high compared to any conventional machines. Coma, which is the backbone of poor quality of vision, completely knocked out by 60 to 70%. So we achieved something very close to what we would see, what I would see in my refractive patients. Close to 4.5 lines improvement in uncorrected distance vision. Gain of 1 line was close to in majority of patients. More than 3 lines, which is in keratoconus by around 37%. 6 diopters of changes. You can see the amount of flattening out here. And if you compare with the other published one, it's way, way different out here. And I've not done any recorrection or any progression at this point of time. This is a collage of image which shows beautiful correction out here. And you can see that, and sometimes, like this picture or this picture, it's very difficult to if to know that this patient has actually had a keratoconus a year back. Amazingly beautiful correction, and you can see how beautifully the lasers platforms are just knocking it off. And you can see these are the few cases where, patients have been glass free now. And this is exactly what you can predict and what you can actually see post-operatively. And this is what I said. Most important thing is how do you regularize the epithelium so that your epithelium becomes the first line of focus. And this is a few images on pellucid. You open up these zones out here, and it makes it more regular. And these are few cases again. So how does this impact the quality of life? We did some quality of life questionnaire, and we found that that improvement of this, especially the tilt and all the other changes, has a huge impact on reduction the abrasions, and in reduction the abrasions had a phenomenal impact on quality of life. So any procedure you do, however good it looks, however good topography it looks, what is important is how does it impact your mental health? How does it impact on your dependency of somebody in your life? How does this impact on activities of daily living? Most important thing today is quality of life, driving. If you can't drive, you can't. How does it impact your reading, work? And you can see this is a jump it is shown from what it was pre-op. And this is from me more than the topography showing beautiful flattening or change. For me, this is what is important. So, being a biologist, I always wanted to see how does it work on the biology because this has less fluence, and every spot has less of those fluence which cause changes. So what I found is you see around 40% reduction in the haze for the same dioptric correction. Those this is very important because this, you do the same, you do a -7. Technically, we see around 30 to 40% reduction of the same haze if compared with any other platforms. And that was very interesting is because the laser is the same, the source is the same. But when I was speaking to those engineers, they were saying that, our fluence is different. As, you end up in having very minimal scar, hardly any scar after 3 months. And that's shown on the densitometry. So what we decided was, can we create some experiments to see if this actually true? That can it actually show some changes like this? So we started looking at biology because it is where the whole process is. You can see that the conventional spots are different, the frequency of laser is different, and this has minimal thermal damage. So that's what it shows. When you have minimal thermal, that scarring what you see as a keratinocytes myofibroblast, you see very minimal of it, and you have hardly very scar there. So even if you treat very high powers, I see very minimal scarring. And this is exactly what I said. You see those patchy things post PRKs or post TRAT, which you see as these kind of changes here. And here you don't see that, even if you do a contralateral work. And there are different biological for this. One of the things is about the way the keratocytes should behave. I call it as a keratocyte awakening, especially when you have different lasers, your TGF betas and TNF alphas, which is inflammatory, would change a lot of this myofibroblasts, for fibroblast to myofibroblast, something like from here to here. And when it becomes that, and that thing actually makes it to look quite dense and scarred. So one of the reasons why we have more scarring is because we have more inflammation in keratoconus. And you can see that different grades of keratoconus had different level of MMPs and tumor necrosis factors. And that would in change a lot of myofibroblasts. The myofibroblast is dependent on these factors. But what I saw with I was modeling is that your change was very minimal. That means it was inducing what I would say is less of TGF awakening. The TGF are there in epithelium, they are there in your keratocytes, and they are in all this. So if you are awakening them less, that means your changes are minimal. But if you're awakening them more, then you become more aggressive change. And that also happens to TNF, the inflammation, because that is there in most of your patients. So what we did was we took the eyeballs, and one pair of eyeballs we did the non-ray tracing. The other with the same 40 microns we used it, and we did some proteomic analysis of the eyes. So that means same patient's eyes, donor eyes, one with ray tracing, other one non-ray tracing, and there were a lot of this processing done with our team in a laboratory. So what we found was the extracellular remodeling proteins was minimal. That means it was remodeling very less. And this is important. The TGF beta mediation was minimal. The oxidative stress was minimal. And anti-inflammatory, the TNF alphas and other things were also minimal. And the anti-inflammatory is this. This is pro. The pro was minimal. The anti-inflammatory, the Renexin A1 protein was very high. So what it means is that exactly what I was trying to say here, that you're creating less of these changes, less of these myofibroblast changes. Because it's creating less of myofibroblasts, you are actually involved in minimal amount of change. So three things we were able to prove is one, the scarring, clinically the scarring was very minimal. The densitometry was different. The third is the confocal microscopy showed very minimal myofibroblast change. So we took this idea, went to the lab, recreated this experiment, and the proteomics, like this is what the proteomics is, showed that it causes minimal amount of changes, especially in all the factors. And your TGF beta, which is one of the drivers of scarring, this is what the TGF beta is, that it goes here. And what does it do? It becomes pro-fibrotic. And the TNF alpha is inflammatory driven, it becomes pro-inflammation. This is in the nucleus. This is the cytoplasm. So receptors are there. The multiple pathways make them to enter the nucleus, and then it closes. And what happens is you end up like this, you end up like this. And here, sorry, you had very minimal change on the TGF as we see here. So this is very important concept that any lasers which is gentle on the ocular health created very minimal changes on the surface. And these are the two pathways, exactly what I showed you here. Here is that these are the two pathways which are necessary for bringing in very minimal awakening of your keratocytes. So to sum up on this part, what I want to say is it's a fantastic optimal lasers. The beauty of this is the way optics is merged to biology. Like healthy, that's what I said. The whole theme of my meeting is romancing the optics and romancing the biology and the cells. So here, the biology and cells create tremendous amount of harmony with each other. And this is what makes it beautiful wound healing. So the whole idea of meetings like this is to synchronize all the aspects what I said, the synchrony of your machines and how it interacts on the tissue, how the biology interacts with each other, and the whole concept of interacting biology with the lasers. This is something which is quite complex, and we're all learning. I'm also learning, just a student here. But it's very important for us to share this because the healing is driven by the biology. And whether it's retina, glaucoma, pediatric, whatever specialty you want. And that's what it is. So the perfection of biology makes it perfect, predictable healing. And what we teach here in these sessions is programmed healing. So what I'll do now is I'll ask my colleague to share the deferred live video. It's around 3.5, 4 minutes. And once that is done, what I will do is I'll come back again to have to answer questions. Or if you have any, you can share your questions in Zoom or in YouTube, and I will be able to answer it to you after this 4 minutes of deferred live surgery. Thank you.
Good evening. We are here today with a very interesting surgical concept of corneal remodeling using ray tracing. Welcome to our first edition of The Thinking Eye, where we bring in very new concepts which is not discussed very frequently, and the ones which will make you start thinking. We do not have any financial gains of any technology being used, but what we want to bring you is something really new from the ground zero. I'm going to talk about a complex ray tracing technology. Complex because a lot of thinking happens in the machine, but when it delivers on the cornea, it makes it completely smooth and beautiful. Today's case for a deferred live is a patient who has keratoconus. He has some amount of refractive error with cylinders, and this patient needs a clarity of vision, something like a normal patient. There are challenges of giving the right optimal correction, the power correction, the thickness, and then of course the concept of how much does the cross-linking would change. So what we do here is the machined iris is connected by different technologies. The machine has, as I've already discussed in my presentation before, this machine has a Precisio, which is the diagnostics. It has the pupillometrics, which gives you the ideal pupil size, which I had shown. And this has a photopic and scotopic. And then it has your topography, elevation maps, and all those factors. When you look at this are your elevation map, it's something similar to what we see, the anterior posterior elevation and the stromal elevation, just a stroma minus the epithelium. You can see that the stroma elevation is 62 microns, the epithelial elevation is 56. That means epithelium is masking it. So this is without the epithelium. When you put onto this segment, something very interesting here is the concept of epithelial ray tracing. Now what is epithelial ray tracing is, the machine assumes that the cornea has two refractive surface on the epithelium. The epithelium here is myopic, epithelium here is hyperopic. That's what the beauty of it is, because the entire surgery here starts with how do you regularize the epithelium, and then it starts with how do you regularize the stroma, and then the total optics. So here if you see, there is a coma, and that coma would change the whole planning once it heals if you have the same type of an epithelial mat here. So in the planning, you have the thickness, the stromal thickness, the epithelium thickness. This is epithelium as a lens. And then finally, this is what the most important part of the procedure is your final planning. We're used to planning which are different. We're used to planning which has the donut shapes. For example, if you have a cone, there's an ablation here, and then there is a hyperopic ablation here, and there's a little ablation here to make it myopic, and all this sort of things. The first thing we have to dissociate from our thought process is this kind of a thing doesn't happen here. And what happens here is something interesting. It happens here is you have the connecting zones. That is one. This area we call the gradient zone. That means they're refractive neutral. They don't have anything out there. And look at the thickness is different in different zones out here. That means that the ray tracing of your cornea, which is if the cornea epithelium is like this, and then your stroma is like this, then your lens, then your ray, and your best fit points are somewhere here, it back traces it and sees to get a perfect vision, how much should I make the cornea more regular? And that is something etched on to this point here. And that is the etching here, what you see. Now, how is this placed like this? So what it does is it takes the mean, the ideal pupil size, that says is 5.8, and it maps the ablation into that ideal pupil size. And this, so there is nothing out here. So because what happens is, whatever is your pupil, and that's the ablation profile which is fit, and this is your ideal pupil, which is a mix of the scotopic and mesopic pupils. And this is what it is actually going to your retina. And we don't want something at the edges here, because we know from the Streiss-Croford law is that anything which falls on that angle on the cone is ignored. So now, if you look at this thing, this is what is going to be planned on the patient's eye. The expected ray tracing is something like this. Expected axial will be something different. It tries to keep the corneal asphericity on. It's not that it's going to make everything flat. It's not that what it wants to do. Now, in the expected, you are trying to see a lot of cornea. And this is, you can see that the epithelium here is more regular. That means that it's trying to keep the epithelium more regular than what it was posteriorly before. Let me just plan this in my OR, and let's see how it shapes up the cornea. Let's move up. This is a deferred life surgery on a very exciting technologies. My 2 decades plus of working with keratoconus, I've seen changes from a type of lenses we used to use, from a rose case, rigid lenses, rose case, scleral, and more advanced lenses. Then we started looking at impacts, became a very strong part of my procedure. And then the cross-linking, we were all the early adopters of these technologies. And then for a long time, from 2008-9 to close to 2022-23, we started playing with different types of laser platform that changed the way we were able to give keratoconus the phenomenal quality of vision. I've been following a technology which has excited me during my first ASCRS, maybe 20 years back. And there were 1 or 2 users of it, an Italian company called IVIS. The why I got excited was way back 2 decades before this concept of ray tracing. They were talking about ray tracing, they're talking about stromal remodeling and multiple other things. And I thought, fantastic, but we never had an access to getting it in India, and I just kept following them up through different sources. I got an exciting opportunity a year and a half back to start using this technology in this country, and one of the first machines here. I don't want to compare any technologies. I love all my technology. You can see all my room has many lasers, at least 3 lasers, which can do lasers for keratoconus. But why I'm excited here is it helps me to think, and it gives you something which is very exciting. And today I'm going to operate on a young person. He has a very complex refractive error, which I have shown in my planning. And we're going to plan and treat what is going to happen in this machine. The advantages of this is that it uses the same pupil size as we got in my diagnostics. If my pupil size is 5.8, it matches here to the same pupil size, same angle, what you have captured. So when you treat, that's why it takes a few minutes for it to capture that in picture. Then you'll see how the ablation platen forms, and then then we do the collagen cross-linking. The newer version of this, which is quite exciting, has an inbuilt cross-linking machine. Now you have a cross-linking machine outside, but it has an inbuilt here. And once you remove the epithelium and after your stroma, it captures the stromal thickness and then maps the laser fluence on the area of it. That means if you have a thinner cornea, it uses different laser fluent. It has a different thickness. It uses a different differential planning, something like the M protocol, which was designed by Cosimo Mazzotta. So let's start this surgery and show you something very exciting. We adjust the light, so you have to keep looking at the red and the green light there. And now you're trying to focus on the same lighting system as we had factored in the diagnostics. Just relax. Just relax. So there's a lot of that time. It goes in the recognition of the pupil, the registration to the same size as the diagnostics, the angle kappa. Now that it is recognized, registration, and once it's done, just had to keep a little dry, and now slide shows that we're ready to go. Just relax. Let's see the area of ablation. Now it's opening up slightly the area of it. The blue is green is the epithelium, red is cobia cone. Now we are finished. Finished this. Aramagidira?
Yeah.
Look straight. Look straight at the light. Light nodi. Look at the light. And then remove the currently fluid from the sac. It's a very deep socket. Dry. Look at the light. I usually keep for 10 to 15 seconds here. Nice wash. Look, do not move your eyes. Do not move your eyes. Do not move your eyes. All the areas. The surgery is done, and then we move you to the other side for the cross-linking, okay?
So that's how it is. So I had some questions which quite interesting questions, which I thought I will discuss with you. The one question was, is it only used for irregular cornea? No. I just showed complex corneas to show that if it can do such complex ones, that means imagine how it can do on regular ones. You can do, it's just an excimer laser. It can do, you can do like your normal ones. You can use uh, PRKs, which is what we commonly do. But I was interesting to see if I can use it on a complex one. So what the number of surgeries we have done is on a complex ones, because it just that really shows the power of the technologies. I mean, common regular ones, anybody can do it. Second question was about can we use it for difference between using alcohol versus this? See, when you use machines like this, which is measuring your epithelium like an lens and trying to treat that epithelium irregularity so that when the epithelium heals after some time, you end up in more regular optics, just shows the power that you are dealing with a very sophisticated system, and alcohol just takes it off any way you want. When the epithelium heals, it will heal the way exactly the same way, because epithelium has memory, and you make a crater, it will heal inside that crater. So I feel that the when you have technologies like this, things like alcohol or mechanical debridement, I don't think the reason at all. See, remember one thing: removing epithelium here is not to give the laser. Removing epithelium is doing a topo-guided treatment on epithelium before you do the topo-guided treatment on the stroma and everything else. So if you have that thought, then you know that how important is your epithelium. So what do you do with the scar? Exactly something similar um, uh, to what we do on a in any other scarring, depending on the depth of scar, superficial scar, steroids, role of lifitegrast, the Trehalose drops. All this works very well because they all work. I showed you the pathways uh, of TGF and TNF alphas. But deeper scars, now you have a role of, again, omega-3 drops. There is a role of ACMIM, the losartan. And also, if it's very deep, then there is a role of doing a PTK. How to avoid over-regularization, spherical aberration, especially when facing erythema sphericity induced by KXL. That is the beauty of ray tracing, is it traces the light and finds out where exactly would be the best way to point the light into your macula. And that amount of the beam is back traced, and whatever you have on the cornea gets regularized. And it factors in some amount of cross-linking due to age, and also cross-linking because of your corneal for KXL. So by doing so, you are not very, not scared about trying to make it hyper regularization and creating a hyperofiction. Is the cone regularized in zone of ideal pupil size? Yes. And that's the zone where you are worried about. That's the zone, what is the zone of thing, what is. See, outside the pupil, whatever zone it is, doesn't matter, because that is not what is going into your retina. So that's how it is. And that's why it doesn't treat the periphery. See, all of you who are used different lasers know that it treats the periphery, it regularizes all those things. You don't see it here. That's one thing which is the beauty of it. There any questions if anybody wants to type, or you can share with, or you can just send me a personal message also. And then just wanted to show something very exciting, because this is something very few places in the world has this machine, but it's picking up well. It's a small company, and there's only two machines in Asia, two or three, and one in Middle East now. So it's a small group of people who work on it, and try to share how to do it, but so far exceptionally brilliant in the way it's working. So, um, it's not that the other technologies were bad. It's just that each one has its own uniqueness, and I find this quite unique in many ways. So, I come to the end of this session, and what I would like to inform you that we will have many more of these sessions every month. Sorry. And please uh, keep follow us on the YouTube or the same page on the Instagram and Facebook, and I will post it on my social media, uh, sys- uh, Facebook and the Instagrams and other things on different things. Maybe, or if you want to know about something, you can send me about anything, important case or anything you want to discuss. Because the whole idea is to create discussion, something like what I did here, bring something totally new, what has not been discussed in other platforms. So have a good weekend and see you. Good night.